Well, thank you everyone for arriving yet again for this continuation of this amazing community of people from all over the place. And I know you've all sort of gone through the work with Lady Bird and I at different times, which we are so grateful for. Just so you know, we will be doing a fourth cohort in February. So if you know other people who want to join, feel free to let them know, and Gail will be sending out the flyer soon. So, and just a reminder, we're trying to alternate some months, just having time and space to check in and see what's going on in relationship to the work of caregiving in all of our lives. And some months we have presentations. And this month we are extremely lucky to have Mike Rabow, who's the palliative care director of many different things at UCSF, to talk to us. Before we get started, though, let's just do a little grounding meditation, coming together from all of the busyness that I know we have all been in all day. Just taking a couple of breaths. Maybe just really letting yourself feel wherever the breath comes into your body. Feel your body sitting on whatever chair you're on, the temperature of the room that you're in. Allowing yourself just to bring into your mind an image or a feeling or a word of how today has been for you, how you're feeling right now. And we'll share those when we go around and introduce ourselves, remind ourselves who we all are on this screen. As I visualize us sitting in a room, in a circle, holding space together. As always, I'm going to start with a poem. And since we're going to be talking about pain and symptom management today, this is a poem by Joseph Bucach called The Remedies. Half on the earth, half in the heart. The remedies for all the things which grieve us wait for those who know the words to use to find them. Penobscot people used to make a medicine for cancer from May apple. And South American people knew the quinine cure for malaria 1,000 years ago. But it is not just in the roots, the stems, the leaves, the 1,000 flowers that healing lies. Half of it lies within the words the healer speaks. And when the final time has come for one to leave this earth, there are no cures, for death is only part of life, not a disease. Half on the earth, half in the heart. The remedies for all our pains wait for the songs of healing. The remedies for all our pains wait for the songs of healing. So to me, so much of palliative care is about these other levels of healing in the words, in the songs, in the heartfulness that comes through when we show up for each other in whatever healing capacity we can. But then there's also the reality that there's a lot of pain and a lot of symptom management that needs to be done that Western medicine is actually quite good at, which is what we will talk about today. But let's go around and just remind each other our names, where we sit in the world, and whatever the image or word was that came to you as we were being quiet to share that. And my circle starts with Sheila.
Hi. um, my name is Sheila O'Donnell. I am a cancer survivor, an amputee survivor, and I have a support group for women living well with metastases. And I'm feeling great. Yeah.
Great. Anne, you could unmute and just introduce yourself over audio.
Good evening. My name is Anne, and I am in San Francisco. I have had a very frustrating day in that yesterday I visited a dental clinic that has been closed for weeks and weeks and weeks and weeks. And they had an emergency number posted, but when I call the emergency number, they answer with goodbye, click. So I showed up in person and made a request. And last night I got a phone call after 9 o'clock with a request to call them. And I've called 22 times today and they don't answer. So, as I said, I've had a very frustrating day. I don't need palliative care yet, but I think my dental situation may kill me.
We hope
Thank you.
not. We hope not. So next in my circle table is Janet.
Good evening. I'm Jan Martinez, and I'm also in San Francisco. And I am going to be attending the UCSF Day of Remembering in a couple weeks. And so I've been thinking about just what does remember mean and what does it feel like? Because it's been 6 years since my husband died, and so my experience of that is changed over that time. And this was his favorite time of year, so it's my favorite time of year too. So I'm feeling lifted up actually, and hopeful.
Thank you. Kathleen Nygaard.
Hi, I'm Kathleen and I'm in Los Gatos, California. And I have had wonderful news with my cousin that I am a caregiver for today. So today is a very hopeful and happy day. Thank you.
Ben.
Everybody, I'm Ben in San Francisco. I'm doing back-to-back Zooms today, which is the most, I would say, energized thing I've done all day.
All right. Kathy Daniels.
Hi, I'm in Denver visiting my son. I'm in the spare bedroom right now, but I live in Bend, Oregon, and I'm here as a Commonweal group co-facilitator, co-host, and we actually just read The Remedies. So that was really amazing. And I'm also a therapist in private practice, working with end-of-life issues. And so I've just got a lot of personal interest around this topic. And thank you.
Wendy. Wendy from San Jose.
Yep, I'm in San Jose, and I'm feeling energized and joyful. I spent several hours outside walking, and the trees are so beautiful, so I just felt happy. It was nice to be out, and I love moving.
Thank you, Wendy. Leela.
Hi, I'm Leila. I'm in New York City. And today I'm feeling very grateful. I have stage 4 cancer and I'm in a clinical trial, and I got my first scan results back today and they were stable. So I felt very happy to see that.
Yay. Glad to hear that, Leila. Neil.
Hey everyone, I'm Neil from Brooklyn, New York, and really been thinking about just the word unity and how unified I've been feeling in work and with people, and just watching how spirit moves through all of us.
Thank you. Camille, you're there. Oh,
Hi, everyone. I'm sitting in my car in Santa Rosa, California, outside my husband's bike shop. I am very full of gratitude for fall and beautiful people. I'm full of gratitude for each of you. And I am a caregiver, having gone through Commonweal with my mom, who has colon cancer, and my aunt, who's 94, and just met with a hospice nurse to learn what hospice provides. And that makes me grateful for hospice, and grateful to you all for suggesting that I learn more about that. And my aunt was open to it. So I feel relieved and grateful.
yay. Let's see, my screen switched around. So Nancy.
Hi everyone, I'm Nancy Titus. I'm in San Francisco. And my word would be redwood trees, 2 words. I took a walk through Stern Grove today and it was really beautiful.
Yay. And Nora.
Hi, I'm Nora from San Jose. I'm feeling calm today. I just walk around. I live near Santa Clara University, so I walk around the campus, and that provided me some calm and serenity. Thank you.
Yay for calm and serenity. Hi, Kita. We just finished going around. If you just introduce yourself, your name, where you are, and 1 word to describe how you're feeling right now.
My name's Kita. I'm in Palo Alto and excited.
All right. Well, thank you all. Again, thank you just for showing up. Did I get everybody? I think so.
No, it's Wendy. Can I go?
Oh, wait. Sorry, Wendy.
Because there's 2 of us.
Right. I can't see you.
I'm Wendy, and I'm normally in Bolinas, California, but right at this moment, I'm in Oakland, California. I have a short poem for today. A friend died, and a friend survived. I had a friend die of cancer yesterday, a week after she was diagnosed. And Richard is home today for the first time after 5 months ago, pancreatic cancer, humongous surgery, and huge complications. So thanks. And normally I'm a hospice volunteer in regular times, and still am, but unused enough, not used enough.
I think you're doing your time, Wendy. Wow. Yeah, everybody's very full lives. So thank you again. And Mike, mostly I'll let you introduce yourself. Just to say, I feel so grateful that Mike is the director of the Mary Center, which is the sponsor of all this work we've been doing together. And I just feel so grateful that you are the person I get to work with, and for your knowledge and your wisdom and your expertise and your humanity. Welcome here, and share whatever you feel moved to share with this circle.
Well, thank you very much. As all of you know, Red Wing, you can imagine, what a pleasure it is for me to be able to work with Red Wing. And my job is pretty easy, sort of just doing whatever Red Wing thinks is a good idea, is how I consider my work. I'm a physician at UCSF, and the palliative care program in the Cancer Center. And I have a focus on education as well in our division of palliative medicine. And I don't know if Gail's is on the line. I can see her photo, but Gail's been a huge part of helping to organize and promote and make successful a lot of the work that we've done in palliative care at UCSF. So thanks to her as well. And I really, really appreciate the invitation to speak. I want to really make this time useful to everybody here assembled. So I'm really, really quite pleased to spend the time answering particular questions. I was planning on talking about pain management to a certain extent, as much as there's lots and lots going on in everybody's life. If someone is in pain, it's hard to do or think about anything else. And I actually, myself was in a bike accident recently, and I've been dealing with a lot of pain from that. So I really know of which I speak, not so much just because of my medical expertise, but just because I've been in pain and taking pain medicine and trying to work and do the other things that I do at the same time. So I have deepened empathy for sure around pain. And I wanted to talk about pain, and I was going to present some slides, but as I said, I'm really looking forward to anyone and everyone jumping in to talk about questions that you have. Although I hope that some of the comments I have are really applicable to folks who are on this Zoom, and that this will be helpful to people. So let me see if I can share my screen. Okay, so yeah, so I was going to talk about pain management for people facing serious illness, and importantly for their caregivers. I think that there is a lot known about the pathophysiology and pharmacology of pain and pain management. And people who are experiencing pain know it well. And then there's this important middle ground between what we know about how to manage pain and people who are having pain, which is the people who are helping, the people who are giving care and supporting those with pain. And I think that that the information often doesn't make it all the way around to family and loved one caregivers. And so that's really going to be the focus that I have. So one of the things that we often joke about, but it's really true, is whether or not the efforts that we make towards pain management are doing more harm than good. And this cartoon shows the physician who comments, I'll give you something to ease the pain, but obviously that the side of that needle suggests that the pain relief attempt is going to be more painful than the pain itself. And so putting everything in proper proportion, really figuring out what's working and how we define what's working is going to be a really important part of the comments I make this evening. Before I go into the some of the details about pain management, I wanted to say a few words about pain in general, and really the question of who cares about pain. And in some ways that question is simple to answer. Of course, everybody cares about pain. But I think thinking about all the ways that our society prioritizes or doesn't on pain management is really key in understanding what we can do and what kind of resources we have. So maybe the first point I would make is that pain management is good for not only for people who are having their pain relieved, but for health systems as well. And those of us who might get involved in advocating for better pain management in the United States could make the point that pain is really expensive. That when people have pain, it leads to increased utilization of the emergency department and the hospital, and of course, lost productivity for people being unable to work or do the activities that they normally pursue. And that another step removed from that is the issue of diversion of pain medicine and what we call aberrant drug-related behaviors or substance use. Those are very expensive for society as well. And we know ultimately that treatment of pain is one of the most cost-efficient things we can do. For pennies on the dollar to provide some pain medicines, we can really keep people out of the hospital and out of the emergency department and out of the clinic. And so it's quite clear that society should be caring about pain, if only for the financial and healthcare utilization reasons. But the law suggests that pain management is super important as well. We know that medical providers have to do end-of-life care, some end-of-life care training in terms of their certification. The Joint Commission, which certifies hospitals, requires that patients are aware that they have a right to pain management. State boards, medical boards require pain management training. And increasingly in the legal setting, physicians are being prosecuted not so much for over-treatment of pain, which is what many physicians might worry about, but for under-treatment of pain. And that there is a significant case in California in 2001 where there was a $1.5 million settlement for under-treatment of pain under the elder abuse statutes. And so although you may find individual physicians who aren't quite aware of this, they're really much more at risk for legislation against them, prosecution of them for under-treatment of pain rather than for over-treatment. But ultimately, we know that the real sort of moral imperative to treat pain is that pain is painful. Pain hurts patients, people, and their loved ones. And that pain actually is the #1 fear of people when they are facing the end period of life. Patients and their families consistently report pain as important at the end of life. And as I said right at the top of my comments, when you're in pain, nothing else matters. It's almost like pain is this big, big hand right in front of your face. And to be able to do anything else in life, we need to at least provide some solace for the pain so we can move pain out of the main focus of our attention a little bit more into the background. So everyone cares about pain, but notably, pain is still incredibly common. So here's a table, a little bit complex, but it shows the prevalence of pain, those yellow bars, for people dying of those four diseases noted, for COPD, which is chronic lung disease, heart failure, CHF, colon cancer, and lung cancer. And you can see, even though we might not associate lung disease with significant pain, in fact, at the end of life, pain is incredibly prevalent among all these different diseases, not just with cancer. But as you can see with cancer, probably about half of people or more facing the end of life due to cancer experience significant pain. And just to be humble, I'll present some data that we have from UCSF, where I work, looking at patients discharged from the hospital. So these are people on their way out of the door of the hospital. Theoretically, they should be feeling pretty good if they're able to be leaving the hospital. But 12% of patients discharged from the hospital at UCSF reported severe pain, and 40%, so nearly half of patients reported moderate to severe pain. So we know not only that pain matters, but that our healthcare system, as a general rule, does a pretty poor job of managing pain. So I wanted to provide a little bit of background for all of us on the Zoom this evening to think about pain management and what we can do. Because I think family caregivers, I think loved ones can be incredibly helpful at helping their loved ones manage pain. We'll talk about pain assessment, pain management, and then the costs and benefits of pain management. And again, you guys have been incredibly respectful. No one's jumped up to interrupt, but I really do encourage folks as you have questions throughout to bring them up. I'm really, really quite happy and look forward to sort of thinking about the questions that you guys have and focusing in on those. So first and foremost, pain assessment. So there's this concept of pain called total pain, which includes physical pain, what's happening in your body, what you're feeling, psychological pain, so the affective nature of pain, what you feel emotionally, and what happens in terms of your own behavior when you're in pain, and then how it affects your cognition when you're in pain, the social elements of pain in terms of how people interact with each other, and then of course, social determinants of health, like whether or not you can afford pain medicine, whether or not there are pharmacies where you live that stock the medicines that are prescribed for you. And then kind of a deep existential or spiritual pain that has to do with loss and fear and other elements of facing serious illness. So the idea of total pain is we can't just look at a wound and say, we know how much pain that's going to cause. We know how much someone is experiencing based on just looking at them or looking at the extent of their cancer, say, on a CT scan. Total pain is this idea that everyone is really summarizing all of their experiences of pain in one expression of pain, one report of pain, and that we need to pay attention to all those elements of pain.
So, Mike, and just Nora put a comment in the chat.
Oh, thanks. I appreciate it because I'm not seeing the chat.
Yeah. That sort of exemplifies this because she's saying her friend is dying or close to the end of life, but she's still doing chemotherapy, but she's dealing with bad pain, with side effects, with the management of side effects, navigating doctors, appointments, lab visits, chasing nurses for questions. She's been to the ER twice recently, and her close friends, Nora included, have been gently and now a bit forcefully trying to initiate palliative care for quality of life, but she is not responding to our suggestions. She's suffering a lot. How does one, as a caregiver and friend, handle relating to that level of pain?
Yeah, well, thank you. It's a important question. I'm not sure I have an answer to it, but that term suffering is an important one, and you might consider the concept of total pain as the experience of suffering, anything that is really causing dis-ease, disintegration of the wholeness of a person. I guess in response to that question, the short answer is I'm not quite sure that there is anything that we can do to get people to do anything. I think it's hard to get adults to do things that we want them to do that they don't want to do, as a general rule. I think we sometimes pretend like we can get kids to do what we want them to do, but I'm not even sure that that's exactly true. But certainly with adults, it is difficult to get people to do what we think makes sense. And ultimately, I guess in some ways, people end up doing what they need to do. And sometimes it's possible that what people need is to fight against the system, to rail against the injustices, to be frustrated by the system. Sometimes, in some ways, that's a need that some people have. And so offering someone a relief of that suffering when the suffering is important to them in some way may not make any sense. Sometimes, of course, people are refusing things just out of ignorance because they don't understand what will be. And we hear this a lot in palliative care. People say, well, I was scared about it before I showed up. And now that I've met you or we've started treatments, I wish that I had started palliative care even earlier. So I do think that for a lot of folks, if we can couch palliative care in ways that suggest it'll be helpful for the goals that people have, then our loved ones might accept that as a way to achieve their goals. So first and foremost, though, I think is really understanding what it is that people are seeking, what it is that people are wanting, and then we can understand the different ways that we might be able to suggest for people to achieve those outcomes. So if people are wanting pain control, pain medicine can be helpful. There are people who believe, as part of sort of a religious approach to their life, that suffering actually brings enlightenment, or suffering brings entry into heaven after someone dies. And so there are people who are dead set against the idea of relieving suffering because they believe it serves them in some ways. So I always really want to make sure that I'm understanding what people ultimately want, what their goal is, and then I can do a better job at helping them pursue it. Not necessarily achieve it all the time, but certainly to pursue it. To be honest, because of the stigma that palliative care has for a lot of people, I often don't talk about palliative care. I rarely use the term and think about things like symptom management. As a matter of fact, the palliative care service I have is called the Symptom Management Service, specifically because palliative care can bring with it so much stigma. But most people are comfortable with the idea of managing symptoms, and that's often a way in, an entree in, a way to gain trust and potentially achieve other goals that people have as well. Okay, well, thank you for that question. And Redwing, please do keep those questions coming, because the way my screen is, I'm not seeing where the chat is. So another way of assessing pain is understanding the kind of pain that people have. There's essentially two main types of pain. One is nociceptive pain and the other is neuropathic pain. Nociceptive pain is when your nerves are doing the right thing in suggesting to you that something painful is happening. So if you stick your hand in a fire, you get nociceptive pain, meaning the nerves are relating the message accurately that there's something traumatic happening to your skin and to your hand. Nociceptive pain is in some ways a complement to that, which is nociceptive pain is the nerves working abnormally, giving you a message that there is something painful going on when in fact there is no injury going on. And folks who've had nerve pain or neuropathic pain may understand what I'm talking about, which is that there isn't any trauma necessarily to your back, but you have terrible back pain because your nerves are being impinged on by elements of your spine. And there's even more subtle ways in which nerves can be dysfunctional and create what's called neuropathy, a painful tingling that you might get as a side effect from chemotherapy. So this distinction can be important because it really can suggest what kinds of interventions or treatments might be most helpful. But ultimately, the key to pain assessment is making the assessment. If you can't assess pain, it'll be really, really hard to relieve it. If you don't understand the pain, it's going to be hard to focus in on it and to relieve it. And in the end, ultimately, the pain assessment that I think is among the most important parts that we do is to understand how pain is influencing people's function. To a certain extent, putting aside sort of the annoyance of pain, if people are still able to go about their normal lives and do the things that they want to do, thinking, talking, walking, interacting with the world, pain may not be as severe or may not be as much of an emergency to address. But if pain is affecting your function, if pain is affecting your goal to live your life as well as you can, it becomes a real urgency to address. So one of the things that I often will ask people to think about is how much pain control do you need? Assuming that in some situations, the only way to get zero pain when pain is super severe is to essentially be completely sedated. I find out from people whether or not they would be willing to tolerate a little bit of pain so that they can be awake, so that they can be conscious. And almost everybody is interested in achieving a level of pain control that's maximal in terms of pain relief, but still allows them to function as well as they can. And so for many people, the 0 to 10 scale for pain leaves them wanting to achieve a pain level of 2 or 3, knowing that that will allow them to take their medicines, have their pain controlled pretty well, but still be able to interact, drive a car, have conversations, write poetry, do all the other things that most people want to be doing.
Mike, I have a question.
Yeah.
I've learned recently about palliative sedation. And so kind of feeds on what you were just saying, like, well, how much pain can you actually take? So specifically when someone's at end of life.
Yeah.
And I know that hospice can do palliative sedation, but do medical doctors when you're in the hospital, can it be if your loved one is dying at home that you could, say, I'd like to do palliative sedation? Can you just talk about that?
Sure. So yeah, so palliative sedation is the idea that the only way to control adequately someone's pain is to sedate them, to have them asleep. So it's sort of a truism to say you can always control pain, and that's true, you always can. If you use enough medication, you can actually just have someone asleep and then they won't be feeling any pain. And so if you've gotten to a place where the pain is so severe that the only way to control it is to have someone be asleep, that is a situation that we would call palliative sedation. And that can happen at home and it can happen in the hospital. Really what's key there is to understand the goal. To understand that the goal is to control pain well enough so that someone isn't suffering, and someone's particular situation is such that the only way that they can achieve that goal of pain control is with complete sedation. Typically, what that means is once someone is asleep, you typically don't allow them to wake up, because you know that or suspect that when they do wake up, they'll be in the same amount of pain that they were in before. So you'll have not achieved that goal of adequately controlling their pain. And so in hospice at home or in the hospital, people can pursue palliative sedation with the idea that pain control is the #1 goal. And then what happens while pain is being controlled is that people eventually dehydrate or without nutrition starve, or the disease itself or an infection or another kind of illness runs its natural course, leading to the death of a patient. So palliative sedation is really a last stop before the end of life, with the idea that pain must be controlled as a primary goal, knowing that the unfortunate side effect of that level of pain control is that patients will eventually die, usually due to dehydration, to an absence of fluid. The reality is that palliative sedation is rarely necessary. So I've been doing this work for more than a quarter century at this point, and have required palliative sedation for patients just a very small handful numbers of times. So I think I've probably done palliative sedation 4 times in 25 years. The reality is that most of the time, with really scrupulous attention to pain control, you can achieve some pain control and still allow people to remain conscious so that they can say goodbye and do other things that might be important to them. But it's important to recognize that palliative sedation is an option. So I think it's reasonable to hear, or reasonable to say, for me to say as a physician, that we can always get your pain under control. And we can almost always get it under control with you still being able to be awake. That's not always true, but it's relatively rare. And for sure, if everyone is accepting of the goal of pain control and accepting of the inevitable consequence of sedation as a mechanism for pain control, being someone dying, then that is a very, very acceptable and reliable way to manage people with really intractable suffering. Yeah, thank you. That's a good question. So I've kind of built up pain management as this this wonderful thing, and in fact, I think that there are a lot of details that your doctors, nurses, and other health clinicians need to know to be able to provide really expert level pain management. And I think it'd be useful for those of us who are caregivers to understand some of the basics of pain management as well, because you'll be able to implement some of these strategies with your loved one. So a few principles that we pursue in pain management. One is prevention. The best way to treat pain is to prevent it from ever having occurred in the first place. So if we can do something, radiation, surgery that stabilizes, chemotherapy that shrinks a tumor, if we can do things that prevent pain, that's an ideal way of providing pain management. We talked about the importance of assessing pain, but that doesn't necessarily mean we should delay pain management while we're pursuing a long workup for the cause of a pain. Because I think of pain at the end of life, especially as an emergency, and we need to really jump on that right away. For sure, treating the underlying cause of pain is important and a very effective way to treat pain. Another big principle is what we call around-the-clock dosing. That it's much easier to keep someone out of pain than to get someone out of pain. Meaning once you use medicines and other things to get someone out of pain, the goal at that point should be to keep them out of pain moving forward and not be fooled into thinking, well, we got the pain under control, now we'll just wait until they have pain again so that we can give them another dose of medication. If the pain is chronic or ongoing, pain management needs to be chronic and ongoing as well. Another important element to pain management is the idea that the right dose is the dose that works. This doesn't apply to every kind of medicine, but certainly for opioid pain medicine, where there's really no maximum dose for any particular person, we really need to pay attention to our goal and whether or not we've achieved our goal of adequate pain management, rather than thinking about, well, I've given a lot of pain medicine, so I'm going to assume that that's good enough. And lastly, we'll talk a little bit about this at the end as well, which is the idea of anticipating and treating the side effects of pain medicine. Because one of my most frustrating things as a palliative medicine doc is when people get so constipated with their pain medicines from opioids that they don't take their medicine because of the constipation. Because we can treat, and we can even more importantly prevent constipation and allow people to continue taking their opioid pain medicines.
You know, Mike, I just want to make a comment here because I think this idea of, you know, both assessing pain and understanding like what the right dose is for people who are caregivers of others. I think it's one of the areas that just becomes so challenging, even and maybe especially when your loved one is on hospice, because you know you're given often very tight parameters of like, well, you can give this one pain pill, you know, every 4 hours. And I think oftentimes caregivers get afraid of like, oh, well, I can't give more than that, or I can't give an extra dose, or I can't give a higher dose. And there's a lot of misconception, you know. So often I know that I've had to counsel people in the home to say, if your loved one's pain isn't being controlled, then call the hospice team or call the doctor, talk to them, because maybe they're not getting either the right dose or getting it often enough. And yet I just have seen so often that it's where family caregivers and friend caregivers get afraid because, you know, the authority is this, these are your instructions and this is the right dose, but that right dose doesn't depend on this particular person. And I think It's just so important to remember that as a caregiver or as someone who's dealing with pain oneself.
Absolutely. I think that's so central. And we're going to run through some information that hopefully will leave everyone feeling a little bit more empowered to demand better pain management. Because the reality is that pain management is not rocket science, but there is a science to it. And there's a lot to know. And if you know it, you can do a much better job at controlling pain. It's completely unacceptable that 40% of patients being discharged from UCSF hospital are dealing with pain. That number should be 0%. So poor pain management is absolutely the responsibility and the fault of the prescribing clinician and the clinical team. And in some ways, what I'm hoping to do is empower caregivers on this call to really understand when it is within your rights to demand that your loved one gets better pain control, and to really figure out when that happens and what that looks like. And we're going to go through some details that I think will address that directly. So I'm going to run through a few of the elements of things that can be helpful for pain, partly because I think many people will know a number of these things, and partly because I don't want to completely lose everyone's attention with these long lists of interventions. But suffice it to say that there's a lot of non-pharmacologic treatments that can help manage pain. And these typically are much safer than some of the medicines that we use, and typically carry with them many fewer side effects. So I think it's always useful to wonder whether or not ice or heat or exercise or movement may be helpful for pain. These are things that you don't need a physician's order for. You don't need prior authorization from your insurance company. You need, a microwave and some rice, or a heating pad. You need an ice tray in your freezer. You need the ability to get up and be active. TENS is transcutaneous electrical nerve stimulation. That is something that gets prescribed by physical therapy or by your doctor. Acupuncture has been shown in many pain situations to be effective. A little bit more difficult, obviously, during COVID, but useful, as can chiropractic manipulation, and visualization, relaxation, biofeedback, and meditation, as well as prayer, all have some evidence behind them. So I think that most of the time when people are dealing with ongoing pain, really paying attention to some of these non-pharmacologic elements is central to being able to keep pain under good control. There are major interventions that people can do that can be helpful for pain. Epidurals and spinal cord stimulation and intrathecal drug pumps can be incredibly useful. And most of the time, people with ongoing chronic, especially cancer-related pain, wait too long to get these interventions. One of those things that people say, God, if I wish I had known that a pain pump was this effective, I would have gotten it earlier. And so thinking about whether or not interventional pain may be useful for your loved one is something to bring up at physician visits. Chemotherapy and immunotherapy can be effective at shrinking tumors, which can improve pain, as can radiation and even surgery. So sometimes we are dissuaded from thinking about these very aggressive interventions for pain because it seems like they are too aggressive or too interventional to be helpful for pain. But in fact, some of these things might be very useful for controlling pain. And then we'll finish talking about the medications that people can use for pain. And they generally break down into three classes: non-opioids, opioids, and co-analgesics, or adjuvant analgesics. And we'll talk very briefly about each of these. So non-opioids, many people know as Tylenol and ibuprofen. And as a general rule, Tylenol is almost always acceptable up to a certain dose. More than 2 grams a day could be dangerous for people's livers, but 2 grams or less a day of Tylenol almost always is safe for almost everybody. and can be added to everything else that people are taking. Ibuprofen, although it's sold over the counter, is actually a relatively dangerous medicine. 1 out of every 200 people probably who uses ibuprofen ends up in the ER with a gastrointestinal bleed because it's one of the side effects of ibuprofen, Advil, Motrin, naproxen. So these things can be very helpful, but they definitely need to be discussed with the treating team. There's also other side effects to the non-steroidals that can involve the heart and the kidneys. And so again, I think about these as relatively sophisticated medicines that require good attention, even though they're available over the counter. Co-analgesics include pain medicines that we use on top of or in addition to opioids typically, and they can include steroids, anticholinergic medicines like scopolamine. Octreotide is a sophisticated subcutaneous or intravenous medicine that people use to decrease secretions in the bowel, and then neuropathic analgesics. So I know that the details of all this is probably beyond what we're interested during today's talk, but I did want to just sort of flash up on the screen a list of the major neuropathic agents so you understand if you or your loved one are taking these medicines, why it is that they might work and how they might be working alongside the opioids. And so a number of different things that have been proven or indicated for other conditions, like for seizures or for depression, are used as pain medicines as well. So one of the common questions I get is, why are you giving me this antidepressant? I'm not depressed. And most of the time, it's because those kinds of medicines can be used as co-analgesics to help with pain management, even though a person doesn't have depression or doesn't have seizures. And so tricyclic antidepressants like amitriptyline or nortriptyline, antidepressants like duloxetine, or Effexor, anticonvulsants, anti-seizure medicines like gabapentin or Neurontin are used primarily not for seizures anymore, but for pain. Opioids themselves can help with neuropathic pain, and a transdermal lidocaine patch, tramadol, and even ketamine might belong on this list as well as non-opioid medicines that can help with pain. Everybody has either tried cannabis or had a friend or family member who told them to try cannabis. And I don't think that's just in the Bay Area, but for sure it is true in the Bay Area. And so I think that most people with ongoing pain should consider whether or not medical cannabis might be helpful for their pain. We know 2 of the many, many strains that are in medical cannabis. So we often think about THC, which is the active ingredient in pot, what gets you high basically, and CBD, which is marketed all over the United States now as a treatment for all sorts of things. And both of these, perhaps in some combination, can be helpful for pain as well. And so I'm really talking with someone who understands the use of medical cannabis well can be important. And I would consider trials an experiment for most people working with a high CBD, a mixed strain, and a low CBD strain in the balance between THC and CBD to see if that can be helpful. There's lots of ways to get cannabis into your body. A tincture, an oil-based tincture, is probably the safest and most convenient for most people, especially given the potential risks that we know come from vaping and just the difficulty of using edibles. So a lot more about medical cannabis. I'm happy to talk lots more about that. But another thing to think about that potentially can spare the use of other medications that cause more side effects. So the last sort of group of medicines I want to talk about are opioids. And that's mostly because opioids are almost always necessary to control the most severe types of pain. And that's just the reality, that the most powerful pain medicines we have include opioids. And for people with very, very severe pain, almost always they require some use of opioids to keep their pain under adequate control. Here's a listing of the medicines. Many of these will look familiar to you. Morphine is sort of the standard opioid that we think about it. There's oxycodone and hydromorphone. There's fentanyl. There's buprenorphine. And then there's methadone. And you'll notice that methadone is on this list. So it's on this list of opioids that can be helpful for pain. As a matter of fact, methadone may be the most helpful medicine for pain, even though we think about it as a medicine that's used to replace heroin for people with opioid use disorder or heroin addiction. Methadone works in that situation because it prevents people from withdrawing from heroin. But in fact, methadone works incredibly well as a pain medicine because it works for both nociceptive pain and for neuropathic pain. It has two mechanisms of action that make it uniquely beneficial for many people, especially with cancer-related pain. So again, another area where there's a lot of stigma around methadone because of its association with heroin addiction. But probably if I was going to have one opioid with me on a desert island, it would probably be methadone as a useful and flexible pain medicine. It also happens to be incredibly inexpensive and can be administered in all sorts of different ways as a liquid and as pills both. So forgive this slide. There's probably too many numbers and symbols on here to make it comfortable for most people to read, but it's important. And this is really where Red Wing's question comes in to my talk in particular, which is thinking about the pharmacokinetics, meaning the timing and the processes of how opioids get used in the body. And this is what's important for us to understand, if not necessarily the numbers, the general principles anyways, about how opioids work. So first and foremost, opioids mostly are excreted through the kidneys. So if someone's having renal failure or kidney failure, it's important to adjust the pain medicine so that they don't get too much. Because once someone's kidneys are no longer processing the opioids, they essentially stay around in your body for a very long time. And so we can typically get by with dosing very infrequently or very small amounts over time. The next bullet point is about something called the Cmax. So this is the maximum concentration. And that concept is important because it tells you how frequently you should be dosing pain medicine. So Cmax is the maximum concentration that the pain medicine will have in your body, and when that maximum concentration is achieved, with the understanding that if you've gotten to your maximum concentration and you're still having pain, you don't have enough pain medicine in your system, right? So throwing more time into the process won't be helpful. Your concentration of the medicine that you took is not increasing once you've achieved the maximum concentration. So when you take a medicine orally, so that's PO is doctor talk for orally, when you take a medicine orally, the Cmax, or the maximum concentration of that medicine, is achieved in about 1 hour. So if you take your medicine and an hour later, you ask yourself the question, is my pain well controlled? You can follow up that question with taking more medicine if your pain hasn't been adequately controlled. Because after an hour, you've gotten the best pain relief you're gonna get. And if it's inadequate, giving it 2 hours, 3 hours, 4 hours, 5 hours, 2 days is not gonna help at all. You're only gonna start to lower your concentration after an hour. So when you're taking oral medicine, after an hour, you should be reassessing, your loved one or you should be reassessing pain. And if pain is still present, it's actually time to take more pain medicine. When we often hear a medicine being prescribed as take every 4 hours as needed, that comes from something called the steady state of the medicine, meaning after 4 after 4 hours, the medicine's achieved a steady state in your body, and the medicine typically only lasts about 4 hours. And so at that point, the concentrations are going to start to decrease. So when you take a pain medicine and it works for you, you can expect to need to take it again in about 4 hours. And that's when the medicine's working well. So you take a medicine, an hour later, you assess whether or not you've got good pain control. If you do, you probably won't need to take more medicine for about 4 hours. But almost for sure, after about 4 or 5 hours, it'll be time to take more medicine. That's for the short-acting or immediate release medicines. The benefit of some of our longer-acting medicines or our delayed release medicines is that they can spread their effect over a period longer than 4 hours. But now you have a little bit of a sense of where that 4 hours comes from, and you have a little bit of a sense of the timing to reassess pain medicine. And I don't care what anyone says, if you still have pain that's very severe after an hour of taking your oral immediate release medicine, you need more medicine. Now, I think it's probably appropriate for you to get direction about how to take more medicine from a clinical expert. But as a caregiver, one of the jobs that you do, one of the functions you perform, can be helping people understand what they should expect from their pain medicine. And you should expect good relief from your pain medicine by about an hour that lasts for about 4 hours total. And if you're not getting that, I really, really implore you to check in with your doctor or nurse about how to adjust the dosing of the medication. So we've talked a little bit about short-acting or immediate release and long-acting or sustained release medications. Ultimately, the principle that we talked about of not chasing the pain, of keeping the pain under control, of around-the-clock dosing, really, really suggests that the ideal pain medicine is one that lasts continuously over time and that doesn't require you to keep on redosing every 4 hours to achieve the effect. Now, for pain that's variable, for pain that's decreasing, having a short-acting medicine that makes sense. We often call it the medicine for breakthrough pain, meaning it's the medicine that you have as an emergency if you're experiencing pain. You use your short-acting breakthrough pain medicine. Most of your pain should be dealt with using long-acting pain medicine so that you don't have to think about whether or not you have pain. You just take the medicine on a regular basis, twice a day or 3 times a day or every 3 days in the case of the fentanyl patch, to keep pain under good control around the clock. So it's the round-the-clock medicine for round-the-clock pain, with the short-acting medicine being used up to every hour for breakthrough pain. So you can see, and I'm going through all of this not because I expect everyone to remember it all or even be able to make use of this information directly, but just to understand that there is a pharmacology, there is a science behind pain medicine that allows us to control pain much better than we typically do in normal circumstances. And that's one of the reasons to find palliative care expertise, is because palliative care clinicians are really good at doing this kind of scrupulous pain management. So I want to talk about side effects because there's one side effect that really, really matters that we're going to talk about, and there's one side effect that really, really doesn't matter that we're going to talk about. So here's a list of common opioid side effects. The common ones happen commonly, and by definition, the uncommon ones happen uncommonly. The most common and persistent side effect from opioids is constipation. If you take opioids, you will get constipated unless you have some other disease process that's leading to loose bowels. But I can tell almost every person that if they take a certain amount of opioids, and it doesn't take very much, that they will get constipated. And so one of the things that's really, really key is to make sure that we are preventing and treating constipation so that people don't have that as a reason to not take their opioids. I hate when I hear people say, I stopped taking my pain medicine because it was making me too constipated. I know that it makes you constipated. What I want to make sure that we all do is treat constipation adequately so that you can continue to use your pain medicine. All the side effects from opioids get better over time. So if you get a little nauseous with your first pill of pain medicine, a little sedated, a little dry mouth, all those things get better after a few different doses of the pain medicine. All the side effects of opioids get better over time if you persist and continue taking the medicine, except for one, and you probably are going to guess it, constipation. Constipation, you never get used to. Your body never acclimates. So you should always be taking a laxative along with your opioids every single time. Now, if they were smart, and I know that they're not, they would package all opioid pain medicines with laxatives, and they just come in the pill, and we wouldn't have to think about it. But no one does that, so we're actually obligated to think about it. If your patient, if your loved one has opioid pain medicine, you should also make sure you know exactly how to manage the inevitable constipation that they'll have. Now, I said we were going to talk about one uncommon side effect, and I want to talk about it by way of discounting it, and that is respiratory depression. So even though much of America may not know that constipation comes invariably with opioids, almost everyone in America carries with them the fear that if you take an opioid, you will stop breathing and die. And in fact, that's not true. The amount of opioid it takes to slow respiration, and it can happen physiologically, your respirations can slow if you get enough opioids. But the amount of opioids that people have to take to slow their respirations is huge. And you essentially have to run through all the other side effects first, meaning you have to get sedated before you are so sedated that you stop breathing. And so if people are awake and it's been an hour for their oral short-acting medicine, meaning they've reached their Cmax, I don't have any worry about them going into respiratory depression. If you're awake and you have pain, and it's been an hour since you last took your breakthrough pain medicine, your short-acting pain medicine, you can take more of it. Respiratory depression, although real, and a horror for sure for people who have respiratory depression in the context of a drug overdose, say a heroin overdose. That is real, and that's what Narcan is for, and that can be very important. But people who are using pain medicines as prescribed, who have pain and who are awake, can tell you they have pain, are not at risk for respiratory depression. So I really want to try and relieve people of that fear, the inappropriate fear of respiratory depression. And in fact, I would call respiratory depression and the risk of hastening someone's death with opioid completely unnecessary. Mostly because we can control almost all pain without sedation, terminal sedation, or palliative sedation as was called earlier, or without respiratory depression. There's actually no evidence that opioids hasten death in the last 48 hours of life. As a matter of fact, the data that we have goes the other way, that when people are in hospice, they tend to live longer, 22 days versus 9 days, if they get adequate pain control. So the more opioids you take, the longer you are likely to live, primarily because you are dealing with less pain. And whatever the explanation for that is, it probably has something to do with your precious life energies being spent on living versus on managing and withstanding the pain that you're experiencing. So let's put off respiratory depression as an unnecessary fear and really focus in on the pathophysiology of the opioids so that we can work with doctors and nurses to make sure we manage pain as well as possible. So we talked about managing the side effects of constipation in particular. And again, this may be a little bit more information than some people want to hear, but if we give people enough senna, we can almost always manage the constipation. So senna is a plant-based laxative. It's available over the counter without a prescription. It's not super expensive. And if you take enough senna, you can almost always manage the constipation that comes from opioids. And I almost don't even need to know how much opioid you're taking or how much senna you're taking. My general rule is if it's been 2 days since you last had a bowel movement, you need more senna. And I typically would add an additional 2 sennas a day to whatever you were taking before. So if you're taking 8 sennas and you're still constipated and don't have a bowel movement in 2 days, I would say add 2 to that and start taking 10 sennas in a day. The maximum dose of senna is 12 in a day. So you can actually take 6 tablets twice a day of senna. In my, again, more than 25 years of doing this, I've only had 1 patient take 12 senna in a day. Almost everybody else can manage closer to 4 to 8 in a day. So with the right amount of senna, you can manage constipation. There's other things that you can take. Miralax is a classic combination with senna. Miralax really softens the stool. And there's even medicines that reverse the opioid effects on your bowel. The most notable one called Movantik for people who with really resistant constipation, Movantik can be prescribed so that constipation can be prevented, it can be treated, and it should never be a reason why people are not taking opioids if they need them for pain. So just a couple more slides, and then I'm looking forward to looking at all the questions that people have. So the second to last slide I have is really about what the role of the family caregiver is. And as you all know, the role of the family caregiver is completely central. I think the family caregiver is essentially doing the unpaid work of a doctor, a nurse, and a social worker combined, if not other specialties as well. And I think those of you on the call who are family caregivers really, really already know this. One of the things that I think can be helpful around pain management is this very unfortunate term that doctors have come used to using, which is as needed, which is PRN in doctor talk. So doctors often write prescriptions for patients saying 1 Norco every 4 hours as needed for pain. And of course, no one really knows what that means. What does it mean as needed for pain? How do you as a caregiver understand what as needed means? And so I typically recommend for family caregivers that you change in your mind this idea of as needed to ask and give, or ask and refuse. So that if it says as needed every 4 hours for pain, I usually recommend to a caregiver that they ask their loved one every 4 hours whether or not they have pain and need more pain medicine. And if they do, you can give it. And if they don't, you don't have to give it. So you don't have to make the assessment about whether or not someone needs more pain medicine. Although I know sometimes you become quite expert at understanding what your loved one is experiencing and whether or not they need more pain medicine. But at the very least, we can stop saying as needed and really think about a routine of asking patients and then allowing them to refuse or to accept our offer of more pain medicine. And then ultimately, I think paying attention to safety is important, but I don't think it's more important than compassion. And that safety is often not the only or even the most important issue for people. That the quality of life that people have and the level of pain that people have often supersede the need for safety. Opioids rarely cause problems in the setting of the end of life and in the setting of very severe pain. And we like to say that opioids typically are sucked up by pain, meaning if you have pain, opioids rarely cause a problem because the opioids go right towards relieving pain rather than creating misuse or addiction. So I want to really try and support people in being liberal in their thinking about how to use pain medicine and to understand that there's a lot of safety built into the opioids, mostly by virtue of the fact that if you give opioids to an awake person, you typically are not causing any trouble. When people overdose, it's because they've taken a massive amount of opioids well beyond what they need for pain or other indications. And you're unlikely to give your loved one a massive amount of pain medicine. You're talking about giving them a dose here or a dose there of their pain medicine. What typically happens, even when people try to overdose, even when people try to use opioids to shorten their life, typically it's difficult to do that. It's quite hard to use opioids to end someone's life. What often happens, even when people take opioids intentionally to try and shorten their life, is they wake up in the morning with having experienced the best night of sleep they've had in a long time. So adequate pain medicine is really important to do. Inadequate pain medicine is easy to do, and probably a third of us underdose pain medicine. But pain medicines are not super dangerous. There's a lot of things that we do, like driving on the freeway, that are probably as dangerous or more than use of opioids in the setting of ongoing pain. So I'm going to just finish with just a box of sort of my take-home points, and then look forward to the extent that people have the time and interest going into the questions. So take-home points being, think about pain medicine dosing every hour for short-acting pain medicines, and think about around-the-clock dosing, especially with long-acting agents, to manage around-the-clock pain. Keep track of the totals that your loved one is taking every day in terms of their short-acting pain medicine, so you can report that back to your doctors and nurses, and they can help adjust the long-acting pain medicine. Preventing constipation, and then remembering ultimately that it's all about function. And if your loved one wants a double dose of their pain medicine at night before bed because they want a good night's sleep, you should give it to them, I think. Because what they want is to be able to sleep so that they can function better the next day, and they don't want to have to function in the middle of the night. So keeping your eye on function as the goal is really, really important. And it really helps us negotiate where on the spectrum of pain management people can fall. And the vast majority of us will fall on the spectrum in a place where we want to function maximally and control our pain well enough so that we can do that. And very, very rarely do we need to use so much pain medicine that people are asleep. And very, very rarely do people get into trouble using their pain medicines as prescribed in terms of lethal side effects from the medication. Almost always, though, do people experience constipation. So that's really what we should be focused on rather than respirations. So I'm going to stop there, stop sharing my screen so that we can talk more about questions or comments or experiences that people have had.
Yeah, thank you. This has been an amazing amount of information. Hopefully people have been able to take it in. There was one quick question about, does Tylenol reduce inflammation?
Yeah, so Tylenol is not an anti-inflammatory, and so it's distinguished from the non-steroidal anti-inflammatories, the NSAIDs, which most of us know as Motrin or Advil or ibuprofen or naproxen. Those do decrease inflammation, and they can be useful for that purpose. When you compare the pain, the analgesic effects of appropriately dosed Tylenol and appropriately dosed ibuprofen, they're considered equivalently powerful for pain. But Tylenol is not an anti-inflammatory, so it won't have that effect. There are times when people use ibuprofen specifically for that, but ibuprofen is not the best anti-inflammatory. Prednisone is probably a better anti-inflammatory. And so often if I'm really trying to achieve anti-inflammation, I'll use something like prednisone rather than ibuprofen, which carries a much higher risk of renal troubles as well as bleeding issues.
Thank you. I just want to invite anyone else to, you can just unmute yourself and ask a question rather than writing it in the chat.
So while you guys are doing that, I saw someone ask about Colace. So Colace is another medicine that was approved by our FDA and prescribed by all our doctors, but has almost no role in human functioning. I don't recommend Colace because it doesn't add anything as a laxative to appropriately dosed senna. And there's been good studies on that. So what people need for opioid-induced constipation is senna, which reverses the effects of opioids. Colace is a stool softener and doesn't do very much. If people's stools are hard, I recommend Miralax, polyethylene glycol, which is also available over the counter. And that will help soften the stools, and senna will help promote a bowel movement. But Colace doesn't add anything. And as a caregiver, most of the people on the call understand that if you could lessen the number of medicines that anyone has to deal with, that's a good thing. So you can throw away your Colace and really just focus in on senna as your laxative for opioid-induced constipation.
It is amazing how many doctors still tell you to take Colace.
I know.
Other questions, comments? Don't be shy. Sheila, just unmute. Yeah.
I got it.
There you go.
Anyway, I just wanted to say thanks. This was fabulous, really terrific. I know a lot about pain, and I've helped a number of people. My loved ones die, and I like morphine myself, but I mean for them. But this was spectacular. Thank you so much.
Oh, I'm super glad it was helpful. I really do appreciate that the level of this talk was somewhat sophisticated, and I don't expect people to understand necessarily or remember certainly all the intricacies. But the take-home point that pain can be well managed is really, really key, and it is your healthcare team's, your loved one's healthcare team's responsibility to do a better job managing pain. That is really, really important, and I really, really encourage you to insist on getting good pain management for your loved one. Nothing else is possible when someone's in pain. You're not going to be able to have those precious moments of sharing stories from the good old days, or expressing affection, or even being able to enjoy the sun if you're in pain. So pain is number 1, 2, and 3 to really make sure we can deal with, so we can go on and do all those other possible opportunities that time and quality of life really presents itself with.
Thank you.
Thank you.
I was just going to offer a connecting question. First, thanks, Mike. It was really interesting to hear all this after having gone certain aspects of it. It was occurred to me as a caregiver on the family side is not knowing this, and how is it that we could be better equipped to be good caregivers to our loved one. And so I hope that the Mary Center finds a way to supplement the palliative care overview that that Grant Smith and the team did last week. And so I think supplementing that with, I'm not sure how to do it, because the caregiver is so stressed and trying so hard to do the right thing, but they don't really know what the right thing is. And I think pain management would be a real helpful skill to convey.
Yeah.
I'm not sure how to make it happen.
Thanks, Jen, and I agree. I in no way intend to create added burden or a sense of responsibility for caregivers, but really, my intention is really just to simplify pain management so that people understand that inadequate pain management is a reason to have your doctors and nurses respond with a way to get better pain management. if you and your loved one agree that their pain is adequately managed, great, you can move on to other things. But if it's clear that the pain isn't adequately managed, then it's time to put in a call to the doc and figure out a way through to better control. One of the things that I think is very reasonable, and many of you probably already do this, is to find out from someone whether or not their pain, where their pain sits on that 0 to 10 scale. And importantly, to know what is acceptable to them, because then you can draw the conclusions. If you have decided previously that a pain score of 3 out of 10 is acceptable or less, and your loved one tells you their pain is 3, then you can say, okay, we're where we wanted to be. If their pain is a 4, let alone a 5, 6, 7, 8, 9, or 10, then they're not getting adequate pain management. And that's not your fault as a caregiver. It is the responsibility of the clinical team. And so I think that the call immediately is to the doc or nurse or the hospice team to say their pain is a 6 out of 10. We had agreed that 3 or less out of 10 was acceptable. So their pain is not acceptable. What can we do? And I think it'll be useful for you to know what pain medicines you have available in the house. I think it'll be useful for you to know what pain medicines people have gotten over the prior 24 hours. Other than that, you don't have any other responsibility other than communicating that information, and essentially, as you do in so many things, advocating for your loved one. But increasingly, we're asking of all doctors to take some primary responsibility in pain management. So Jan talked about this idea of specialty palliative care is not enough. Like, you know, she saw on that webinar, like all the palliative care docs in the Bay Area, and there weren't that many. So we know that it's not all about having people cared for within palliative care. It's about what your routine pulmonologist, your routine cardiologist, your routine oncologist, and their clinical teams can do. And so we are trying to get basic pain management as a responsibility that everyone who works with patients can help manage. So we are putting into the note that all oncologists will be using at UCSF a requirement that they look at the pain score that the nurse checks the patient in with, and that they let they put in the note what they do about that pain level. So if a pain level is at a 4 out of 10, as reported by the nurse, then the doctor is required to say in their note that they saw that and they ignored it. They saw that, they found it acceptable. They saw that and they adjusted the pain medicine. They saw that and they made a referral to palliative care, but that they did something with it. Because I totally agree with you. It is the doctor's responsibility to help patients get their pain levels into an acceptable range. And if we don't require doctors to do that, we know exactly what happens, which is they focus on other things. They focus on chemotherapy and they focus on surgery and they focus on all the other things that doctors focus on, which is a good thing. I'm not wanting them to ignore cancer care, but we have to really all agree that pain management is primary and severe pain is an emergency for people that needs to be addressed really, really urgently.
And Jan, I just want to say, I think your idea about, how to continue the conversation, how to have information more accessible. I think it is an important idea. I mean, certainly in terms of the Mary Center being a resource, that it's something we could look at in terms of having, some caregiver resource pages. I'm so aware that the number of times I've taken care of someone dying at home and, they're loved basically because hospice teams are so strapped these days for time and energy. A lot of times, like, the medicines are dropped off and some basic instructions are given, but when you're a family caregiver and your person is really, really sick, everything is overwhelming. And so trying to decipher, well, which medicine do I give for what and how often do I give it? And just, I think maybe for people to know there's some resource page that can help them simply understand might be a helpful thing, because it is, I think, one of the hardest things for family caregivers, especially at the end of life, is to feel comfortable being the one there 24/7, with this idea of assessing pain. And as Mike was saying, this idea that give it as needed. No, you give it. Yeah. Are there any other, I'm aware we're at time, a little beyond it, but I just want to, if there's any other critical question or comment from anyone. Say, look around the circle. Kita? Unmute.
Just a giant thanks, Mike. It's been very helpful. You should know that your words will go a long way, just not only with caregivers, but with other family members to like do more education. It's great. Thank you.
Wonderful. Oh, I'm happy to hear that. Thank you. Yeah. I certainly, maybe the last word I will say is just to express my gratitude for all of you who are caregivers. I was just saying earlier today to a caregiver, it is a job that you are completely untrained for, you're completely unsupported in doing, and you are held responsible for many people's, many professions' jobs, and you do it with such deep love. It is an amazing service that you're providing. And I unfortunately know I might be the only doc who expresses gratitude to you, but thank you. Thank you for all that you do.
Well, thank you everyone once again, just for showing up here, for staying as part of this incredible community of people learning and continuing to grow together. Please have a safe holiday season, whatever that is for you. If there's something specific that you need or have a question of, you can always email me or email Gail and she'll get it to me. We will reconvene again in January, just after the holiday season. Stay warm, stay safe. Much love to everyone. Take care.